Welcome to the Weekly Neurology Deep Dive, produced by Amara Gavanini. Before we jump in, just a reminder. This session is purely for educational purposes. There's no commercial goal here. We're summarizing the source material, but we strongly recommend you read the full published paper for all the details.
Right, and today we're tackling something really central to acute stroke care. It's that question of optimal timing for starting direct oral anticoagulants, DOACs, after an ischemic stroke in patients who also have atrial fibrillation. It's been a point of debate for a while.
Absolutely. And for those of you needing the key takeaway right now, here it is. The Catalyst individual patient data meta-analysis provides really compelling evidence. Starting DOACs within 4 days after an acute ischemic stroke in AFib patients significantly cuts the risk of recurrent ischemic stroke and also a combined outcome that's recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke all within 30 days. And crucially, it does this without apparently increasing the risk of symptomatic intracerebral hemorrhage. So the bottom line is, this strongly supports earlier DOAC initiation in your clinical practice for, well, a broad range of these patients. Okay, let's unpack that. Because for years, as neurologists, we've really grappled with this, haven't we? When exactly do we start anticoagulation after an ischemic stroke in someone with AFib? The optimal timing, especially for preventing those early recurrences, has been, well, murky. Largely because the big, pivotal DOAC trials establishing long-term use, they actually excluded patients with recent acute strokes, left a real gap for us in the immediate post-stroke phase.
It really did. And you have this inherent tension, right? And on one hand, starting a DOAC early makes intuitive sense. You want to prevent another clot, another cardiac embolic stroke, which can happen quite soon after the first. But on the other hand, there's always been this significant concern, this fear almost, about hemorrhagic transformation. The infarct itself bleeding. And if that happens, especially if it's significant, it can dramatically worsen the outcome.
Turn a potentially good recovery into something much worse.
Exactly. So clinicians were kind of walking this tightrope. Prevent the clot, but avoid the bleed. That's the dilemma the Catalyst collaboration really set out to resolve by pooling data in a very smart way.
Right. So to tackle this uncertainty, the Catalyst group used a really robust method. They did a systematic review, and then this prospective individual participant data meta-analysis of randomized trials. And just to emphasize that IPD meta-analysis isn't just pooling summaries. They got the data for each individual patient. That allows for a much more granular, powerful analysis.
Precisely. It's a huge undertaking. They searched the major databases, PubMed, Cochrane Central, Embase, looking for trials up to March 16th, 2025. And they were specific. Needed to be pre-registered, randomized trials comparing early versus later DOAC initiation using approved doses in patients with acute ischemic stroke and atrial fibrillation.
And how did they standardize early versus later? Because different trials probably use different cutoffs.
They had to harmonize it exactly. For the meta-analysis, they defined early as starting the DOAC within 4 days of stroke onset, and later was defined as 5 days or more after onset. This 4-day mark became the key comparison point.
Okay. And they found 4 main trials that fit the bill: timing, ELAN, OPTIMAS, and START. But you mentioned harmonization. Can you give an example of how they aligned the timings from, say, ELAN or START?
Sure. It was quite nuanced. For ELAN, for instance, they only included participants with moderate stroke severity from that trial. And within that group, ELAN's early arm was within 48 hours and later was 6 to 7 days. Both fit the Catalyst definitions. For START, which looked at mild to moderate strokes, starting on day 3 was considered early for Catalyst analysis, and starting on days 6, 10, or 14 in START were all grouped into the later category for Catalyst. It required careful mapping based on the individual trial protocols.
Makes sense. So with all that meticulous work aligning the data, what was the primary outcome they focused on to give us that clear answer?
The primary outcome was a composite endpoint measured at 30 days after randomization. It included recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke. It's a well-chosen composite because it captures both the efficacy preventing more clots and the key safety event, the symptomatic bleed.
And secondary outcomes?
Those included the individual components of that primary composite, looked at separately at 30 and also 90 days, plus all-cause mortality.
Okay, so they have this huge data set of individual patients. How did they actually analyze it all to account for the different trials and get these results?
They used what's called a one-stage individual patient data meta-analysis. So instead of combining results from papers, they pooled all the raw patient data. Then they analyzed that unified data set using a generalized linear mixed effects model. That's important because it lets you properly account for the fact that patients came from different trials, which might have slightly different baseline risks or procedure.
Right, handles the between-trial variation.
Exactly. The results are mostly presented as unadjusted odds ratios with 95% confidence intervals. And for the primary outcome, they also calculated the absolute risk difference, which is often, more intuitive for clinical practice. They didn't pre-specify a sample size. The goal was just to combine all the available high-quality patient data they could find.
Okay, let's get to the results then. The numbers. This involved a lot of patients, right?
It did, a really robust number, 500 and 441 participants in total.
And what did the typical patient look like? Demographics, stroke severity.
The mean age was about 78 years, 77.7 to be precise. Just under half, 45.4%, were women. The median National Institutes of Health stroke scale score on admission was 5. The interquartile range was 3 to 10.
So a good mix, but leaning towards mild to moderate strokes overall.
Yes, that's representative of many stroke populations.
And which trials contributed most of these patients? And what was the actual median time to starting the DOAC in each group?
The OPTIMAS trial contributed the most, about two-thirds, 66.6% of the patients. Then came timing with 16.3%, ELAN with 13.9%, and START with 3.3%. As for the timing, it clearly separated the groups. The median time from onset to starting the DOAC was 3.0 days in the early group, and it was 7.2 days in the later group. So the study design definitely achieved that separation around the 4-day mark.
Okay, the moment of truth. The primary composite outcome, recurrent stroke, symptomatic ICH, or unclassified stroke within 30 days. What did they find? Did early win out?
It did. The primary outcome event occurred in 2.1% of the participants in the early DOAC group. That was 57 people out of about 2,700. Compare that to 3.0% in the later group, 83 people out of a similar number. The odds ratio comparing early to later initiation was 0.70.
So a 30% relative reduction.
Exactly, with a 95% confidence interval from 0.50 to 0.98, and the p-value was 0.039.
Statistically significant.
Yes. And the absolute risk difference was just under 1%, minus 0.93%, clearly favoring early initiation.
An absolute risk difference close to 1%. That translates to a number needed to treat of about 108 to prevent one of these primary events within 30 days. That feels clinically relevant. What about recurrent ischemic stroke specifically? That's often the main driver we're trying to prevent early on.
Yes, they looked at that individually too. An early DOAC initiation significantly reduced recurrent ischemic stroke. It happened in 1.7% of the early group versus 2.6% of the later group. The odds ratio there was 0.66, confidence interval 0.45 to 0.96, and a p-value of 0.029. So a clear benefit in preventing further ischemic events.
Okay, that's the efficacy side. Now, the crucial safety question. Symptomatic intracerebral hemorrhage, the reason for delaying in the past. Any increase with starting early.
This is perhaps the most reassuring finding for clinicians. There was absolutely no evidence of an increased risk. Symptomatic ICH occurred in 0.4% of patients in both groups, exactly 10 patients in the early group and 10 patients in the later group. The odds ratio was essentially 1.02 to be exact, with a p-value of 0.96. No difference.
Wow.
And similarly, no significant difference in major extracranial bleeding either. So the main safety concern driving delayed initiation just wasn't borne out in this large data set.
That's really practice-changing potential right there. Did these benefits, especially for the primary composite outcome, persist out to 90 days, or was the effect mainly concentrated early?
That's an interesting point. When they looked at the primary composite outcome at 90 days, there was still a trend favoring early initiation. The odds ratio was 0.88, but it was no longer statistically significant. The p-value was 0.40.
So it suggests the main punch is delivered early?
It does suggest that. The primary benefit seems to be in reducing those very early recurrent embolic events in that first month. After that, perhaps both groups being on anticoagulation long-term starts to equalize things more.
Now, a question that always comes up in practice. Did this benefit of early initiation hold true across different types of patients? What about those with more severe strokes? Or those who got thrombolysis or thrombectomy?
That's a major advantage of having the individual patient data. They could do detailed subgroup analyses. And the finding was quite striking. They found no detectable interactions between the timing effect and any of the pre-planned subgroups. Meaning the benefit of early DOAC initiation, that odds ratio around 0.7 for the primary outcome, was consistent. It held true regardless of the baseline clinical stroke severity, whether they got reperfusion therapy or not, or whether they were already on anticoagulants before the stroke.
That's incredibly helpful. It simplifies things, suggesting the benefit is broad.
It really does. It provides reassurance across a wide spectrum of the patients you typically see.
So let's boil this down. For the neurologists listening, dealing with these patients day in, day out, what's the core message from Catalyst for their clinical practice?
The message is pretty clear and quite strong. The findings robustly support starting a DOAC within 4 days for most patients with acute ischemic stroke and atrial fibrillation. It directly challenges that older, often routine practice of waiting, sometimes for a week or even 2 weeks, because of that fear of ICH. This data suggests that delay is likely unnecessary for many and may actually be exposing patients to a higher risk of early recurrence without a clear safety trade-off. It's a significant shift towards acting sooner.
And what gives this study the weight to suggest such a shift? What are its key strengths?
Well, first and foremost, the sheer size, over 5,400 patients pooled from high-quality randomized trials across different regions, that provides a lot of statistical power and confidence. Second, the generalizability. The patients in Catalyst looked very similar to patients we see in large real-world stroke registries in terms of age, stroke severity, use of reperfusion therapies, and importantly, nearly a quarter, 24.4%, had moderate to severe strokes, NIHSS scores over 10. So it's not just mild strokes. The benefit seems to extend into more severe groups, which was a key area of uncertainty before.
And the IPD approach itself is a strength.
Absolutely. Being able to do those subgroup analyses with the raw data adds a level of detail you just can't get otherwise.
Okay, it sounds very compelling. But no study is perfect. What limitations should neurologists keep in mind when applying these findings?
Yes, definitely important to consider the limitations. First, that 4-day cutoff for early was sort of imposed by the available trial designs. It's possible, future research looking at timing as a continuous variable might find nuances. Maybe day 2 is better than day 4 for some, or day 1. We don't know that granularity yet. Second, because of the different timings and criteria in the original trials, not every single patient randomized in those 4 trials could be included here. It's still a huge number, but not 100% capture. Third, the diagnosis of recurrent ischemic stroke in 3 of the 4 trials was primarily clinical, not always requiring imaging confirmation, although they did use expert blinded adjudication panels to try and standardize it.
So some potential for misclassification there. But
A small potential, yes. And finally, the rate of symptomatic ICH was actually quite low overall, only 0.4% in both groups. While reassuring, such low event rates mean the study might have been underpowered to detect a very small difference in ICH risk if one existed.
Right. And crucially, as is often the case, these findings probably don't apply to everyone. Specifically, patients with very severe strokes, say NIHSS over 20, or those with really large space-occupying hemorrhagic transformations. They weren't well represented.
Exactly. Those patients were largely excluded from the original trial, so Catalyst can't really tell us about them. For those very high-risk individuals, clinical judgment and careful individualized assessment remain paramount. You still need to weigh those risks very carefully.
Okay. So to wrap up the main findings.
In summary, this large-scale individual patient data meta-analysis gives us pretty compelling evidence. It shows that starting a DOAC within 4 days after an ischemic stroke linked to AFib is effective. It reduces early recurrent stroke and the composite outcome. And critically, it appears to be safe without increasing the risk of symptomatic ICH in the broad population studied. It strongly challenges the old habit of routine delay and suggests that, for many patients, earlier anticoagulation is likely the better approach to prevent those devastating early recurrences.
It certainly suggests that maybe our default should shift. For many patients with acute ischemic stroke and AFib, perhaps barring those specific exclusions like very severe stroke or worrying hemorrhage, maybe starting the DOAC within those first 4 days should be the routine rather than the exception. It raises an interesting point for you as neurologists. How might this strong evidence change the conversation you had with patients and families? Explaining that balance of risk and benefit, especially when maybe previously the tendency was to wait, it seems to offer more confidence for earlier action now.
You've been listening to the Weekly Urology Deep Dives, produced by Amir Gavanini. As always, for the full nuance and data, please do consult the original publication. Thank you for joining us for this deep dive into this important clinical update.